After you, Sheikh.
Yeah, good evening. Thanks, Shripad. Yeah, okay. So today we're starting off with the disorders of neurulation. So in primary words, we are talking about the embryology of the nervous system, and the whole process of the formation of the brain is neurulation. So that is where we stand. So today I'm going to talk about neurulation and the disorders of neurulation. So if we look at neurulation per se, you have primary neurulation and secondary neurulation. And these processes are because of the inductive effects on the dorsal aspect of the embryo by the underlying mesoderm. And this eventually lead to the development of the brain and the spinal cord. So primary neurulation is basically the development of the brain and the spinal cord up to the lumbar region, whereas secondary neurulation is the development of the caudal sacral segments below the lumbar region. So there's a slight difference in the process of primary neurulation and secondary neurulation, and most of the conditions that we actually look at, be in pediatric neurology or sometimes in the adult world where you have the meningomyelocele, that is primary neurulation disorder. So what is the molecular basis of neurulation? Because we want to know some. So these are intrinsic patterning genes and the embryonic signaling pathways. So you have the embryo which is aligned in a flat shape, anterior posterior. So you have the notochord which forms, and the notochord actually then is the primary basis from where the neurulation process starts off. The neural plate. So the genes which are responsible are the Hox transcription factor genes, which provide the positional aspect for the spinal cord and the hindbrain. That is very important. You need to know in relation to your body, where does it actually stand. And the other genes, which is the sonic, hedgehog, wind pathway, and the bone morphometric protein genes, interact to develop the cells along the dorsal and the ventral axis. So you have the dorsal, so just above the notochord, you'll have the dorsal, but ventral to that will be the ventral axis. So there are certain genes which actually are important, but you also have environmental factors which are responsible for neural tube defects. And primarily these are the maternal factors. So you have maternal obesity, maternal diabetes, pre-pregnancy weight gain. And in our cases, from a neurology standpoint, we're looking at exposure to teratogens, primarily the anti-epileptic drugs, but sometimes radiation and other things can also lead to neural tube defects. So what is primary neurulation? Primary neurulation begins in the 3rd week and is completed in the 4th week of gestation. So you can see on your right hand side, you can see the neural plate which is being formed, then the neural groove which develops, and then you can actually have the invagination of the neural plate, separation, and then you have the neural canal and the neural tube which is formed. So it begins as a plate of tissue in the ectoderm, and it's induced by the underlying notochord and the mesoderm. It invaginates and closes to form the neural tube and the neural crest cells, which are in between the neural tube and the overlying covering. So what is the primary role of the neural tube? It essentially gives rise to the central nervous system. The fusion of the neural tube first occurs at the point where you would actually have the lower medulla, and this occurs on day 22. The fusion moves rostrally from that point up and then that point down, which is the caudal. And the anterior neuropore closes around day 26, posterior neuropore closes day 28. And these dates are important for understanding which level or which degree of neural tube defect you are going to visualize. And the posterior closure occurs at the upper sacral level. Now, what is the role of the neural crest cells? So they actually formulate other parts of the nervous system, which essentially are dorsal root ganglia, sensory ganglia, and autonomic ganglia, Schwann cells, cells of the pia and the arachnoid, and the cells of the adrenal medulla, plus the melanocytes. So that was the primary neurulation, and then we come to the secondary neurulation. So this is the process of formation of the caudal neural tube below the lumbar region. It's a sequential process where you have the canalization and the retrogressive differentiation, which means that the tissue which is formed, it is canalized, and the canal actually then moves up and then abuts the cell mass which is there ahead, and then there is retrogressive differentiation, which means that the caudal cell mass regresses to form the phylum terminal. That is the process, and then there is the connection between the primary and the secondary neurulation processes, and you have the entire spinal cord and the CNS of the brain being formed. What are the disorders of primary neurulation? So you have craniorachis totalis, anencephaly, myeloschisis, encephalocele, myelomeningocele, along with Chiari type 2 malformation. So encephalocele, myelomeningocele, Chiari type 2 are the ones that we actually commonly encounter, but the other ones which are not really very big. So what is craniorachis? So it is a total failure of neurulation, which means that it's only the neural plate-like structure and there is no covering overlying. Now, if you remember that the fusion starts at the level of the lower medulla, which is the day 22. So this defect has to arise before the day 22, because then the fusion would have taken. So this is a failure of neurulation, which means that the fusion also is not going to take place. And they usually lead to spontaneous abortion. So this is one of the image which I picked up from wall. And you can see that there is nothing there, to just the neural plate which is being seen here. Anencephaly. Now, anencephaly is basically failure of the closure of the anterior neural tube. The exposed neural tissue is formed, whatever remains exposed is because of the failure of the closure. And you have two varieties, holoanencephaly and meroanencephaly. Holo is where the defect is up to the foramen magnum, and mero is where the defect does not extend up to the foramen magnum. And again, because it is the anterior neural tube defect, you have to look at the anterior neuropore to day 24. So this has to be before day 24 of life. And you would definitely encounter polyhydramnios in these pregnancies, usually stillborn 75%, and remaining do live only into the neonatal period. By day 14. According to one study, most of them had actually passed away. Excuse me. The incidence is 2 per 10,000 live births, more in whites and poor socioeconomic status. The reason that they manage to survive only for a short period, if at all, is because of a rudimentary brain stem. And this is how you would actually look at. So above the orbits, you do not find anything, and that is the exposed skull from the posterior view. Myeloschisis. So this is the failure of the closure of the posterior neural tube. You have a neural plate-like tissue, but without the covering of the overlying vertebrae or the skin. Again, before day 24, usually stillborn, and there is anomalous formation of the skull base and the upper cervical region. This is encephalocele, myelomeningocele are the ones that are commonly encountered. So encephalocele is a disorder involving closure of the anterior neural tube, usually seen in the occipital region, then the frontal region, followed by the temporal and the parietal region. And what we essential to have neural elements present within the sac. Otherwise, you will probably look at it as a meningocele. So this image actually shows that you can see a defect in the occiput. You can see a large sac-like structure, and you have the arrowhead which shows that some neural element is actually present within the sac. And this image actually shows an occipital encephalocele as well as a lumbar meningomyelocele, and usually seen day 26 of life. Normal tissue, usually the occipital lobe, is present within the sac. There is communication to the cerebral cortex through the sac of that whatever rudimentary tissue which is there. And 50% of the cases have hydrocephalus. This anomaly can be associated with Chiari type 2 malformation. Within the brain, the cortex, you do have abnormalities. You have subependymal nodular heterotopias can be seen in a spectrum of patients. And this is one syndrome that we should be aware of, Meckel syndrome, where you have the encephalocele, microcephaly, polydactyly, polycystic kidneys, and ambiguous genitalia. For encephalocele, neurosurgical intervention is required for all the patients, and outcomes usually is better for anterior encephalocele compared to the pole, which means that the frontal vis-a-vis the occipital ones. What we're looking at next one defect is the myelomeningocele. This is failure of the posterior neuropore closure, and the most common site is in the lumbar region. You can extend it, so we say it a thoracolumbar or a lumbosacral or a purely lumbar. Antenatal detection is easier now with the use of ultrasonography as well as with the fetal MRI techniques. And what I've shown here is basically in the image A is meningocele and sonography as well as the MRI, which is showing the same sac, which is communicating to the intraspinal level, but there is no spinal element which is present within the sac. The moment spinal elements are present within the sac, it will be termed as myelomeningocele. The location and the degree of the defect determines the outcome. So the lumbar ones are the ones which probably will have the most significant problems, usually present with flaccid paralysis, sphincter dysfunction, and foot deformities. Usually have a severe sensory loss, which leads to trophic ulcers. Hydrocephalus may be seen in 70 to 80% of cases, and occasionally, even though in most the intellect is preserved, you may have cognitive and language disabilities. For the treatment aspect, fetal repair of MMC usually leads to a better outcome and usually is offered between 22 to 26 weeks. Postnatally, if you encounter a case of MMC, surgery is usually necessary for immediate closure of the defect. And the secondary surgery would be because there would be cord tethering, so you would have to do a detethering surgery. Multi-specialty management with the surgeons, orthopods, physios, orthotic support, urologist because of the sphincter dysfunction, a pediatrician and a neurologist. So it's a multidisciplinary management and a multi-specialty care that is required for these kids. Primary prevention is usually by folate supplements. So if you have a history, you can always begin. Otherwise, the best time to start is 4 weeks before conception. Hydrocephalus. There is a reason for hydrocephalus to be seen in patients with MMC, and 70 to 85% will have hydrocephalus. Overt signs are usually noticed within the first 2 to 3 weeks of age. Serial ultrasound monitoring or MRI is required, usually tackled with ventriculoperitoneal shunt with or without posterior fossa decompression, because sometimes the shunt itself may relieve some of the pressure in the posterior fossa, and you may not require a subsequent surgery. And in non-shunted, this may eventually lead to arrested hydrocephalus. So now the reason why you actually see this, if you look at this image, you can see where the letter A is, you can see the descent of the cerebellum, and in the B, you can actually see the sac. Now the CSF actually keeps on draining and it drags the upper neuraxis into the foramen magnum, and that is why you have the descent of the cerebellum, you have the descent of the medulla, elongation of the pons and the medulla, stretching of the lower cranial nerves. Once the defect is closed, everything actually moves back because the CSF drainage is stopped, and you actually have the ascent of the posterior fossa structures, which means that some amount of the carry can be corrected with the fetal surgery. But this is the reason why it presents, and if you do not offer a fetal correction, fetal correction for the MMC, you may end up having a child who has KRE2 associated with the meningomyelocele. Now, because of the brainstem involvement and the lower cranial nerves, you have a variety of manifestations. Along with this, you can also see the syrinx which is developed in the upper cervical cord, sometimes in the middle, and you require the so syringostomy is not required, because if you decompress the posterior fossa or the ventriculoperitoneal shunt, the syrinx by itself can get settled. KRE2 in association with MMC has an increased risk of mortality. So what we do is suboccipital craniectomy for the posterior fossa decompression, a ventriculoperitoneal shunt, and the shunt itself tackles the syrinx if the syrinx is actually present. Now this is the last part, which is the occult spinal dysraphism. So you have the skin covering which is present over the defect, whereas earlier ones we did not have that. And the manifestation depends on the severity of the underlying neural tube defect. So most common presentation would be a slowly progressive weakness with spasticity, sensory loss in the lower limbs, gait difficulty, bone deformities, and sphincter dysfunction. Possibly will be asymmetric. So what are the occult scenarios? You have the spinal cord lipoma, dermal sinus tract, spina bifida occulta, and split cord malformation, which is probably much more commoner. So you have the diastematomyelia, where you have a vertical septum which divides the cord longitudinally into two parts, and it may extend up to many segments. This probably gives rise to progression of the symptoms over time. And because of the tethered cord in such scenarios, most of the problems evolve as the child enters the second decade. So what are the disorders of the secondary neurulation? So you have a fibrofatty phylum terminal, which may be associated with the low-lying cord, again leading to the same problems of motor, sensory deficit, and sphincter dysfunction. Or you can have a sacral agenesis, which can be a part of a caudal regression syndrome that we see in mothers of in infants who are born to mothers with diabetes mellitus, and there is absence of the caudal segments, or it, as I mentioned, it's part of a caudal regression syndrome. So these are the spectrums and the varieties of neurulation disorders or the neural tube defects that we actually see. Common ones to be focused would be encephalocele, myelomeningocele, and the treatment for them, remember, is multidisciplinary. Thank you.
Very nice, Dr. Patil. Thank you. I think you made this relatively difficult subject quite easy for the PGs. I hope they got the hang of it. Thank you very much for this really lucid lecture. Let's move on to our second lecture for the day, which is on approach and evaluation to regression of milestones. And it's by Dr. Ramshekhar Menon, who is a consultant neurologist, epileptologist, and in charge of behavioral neurology at Sri Chitra. So I welcome him and I request him to.
Is my screen visible?
Yes.
Thank you, Dr. Pujari, for giving me this invitation. My job is to basically tell you about what a neurologist's approach should be towards regression of milestones, both in terms of the clinical approach as well as evaluation. So just take you through some basic concepts. As all of you are aware, with regard to adults more than 18 years of age, we talk about the process of cognitive decline as a dementia, but less than 18 years of age, we talk about loss of milestones, or which may be previously acquired or from a previously attained level of functioning in terms of neurodevelopmental regression. So neurodevelopmental regression, as you can see from the line diagram also, is nothing but a sudden or gradual loss of previously acquired developmental milestones. It is important to know at baseline as to what is the developmental status of a child when they present to your clinic. So developmental delay in its absolute terms is defined as a developmental quotient of less than 70% within a given developmental domain. So developmental quotient is nothing but the developmental age upon chronological age, which is adjusted for prematurity. Global developmental delay is a significant delay in 2 or more developmental domains. And intellectual disability basically refers to significant limitations in both intellectual functioning as well as in adaptive behavior. And this may be in the conceptual domain, that is acquiring of conceptual skills, social or adaptive skills. And this term is usually applied to children beyond 5 years of age. So when we start taking the history from a child who presents to your clinic with history of regression of milestones, certain important inquiries which you need to make are parental consanguinity, prior unexplained loss of a child or multiple miscarriages, birth history, postnatal history, whether the child had a recent episode of meningitis, encephalitis, or major head trauma. And then comes the domain of regression. So what we often use in the clinic are developmental screening tests. Now, as neurologists who see children, it is important that you have a fair idea of what are the core developmental milestones of the child. And what you need to understand is that there is a range within which certain milestones are achieved. And you need to go as per a specific domain as to whether the regression has happened in the gross motor domain, the fine motor domain, or the social domain, or the language domain. But please note that there is a wide variance in this, and you cannot say in absolute terms as to if a child did not achieve a given milestone at a given time point, that the child has a definite delay. You must consider the range at which these milestones can occur. So that is why the Denver Developmental Screening Test, or in the Indian subjects for children or for infants less than 2.5 years of age, you can use the Developmental Assessment Scale for Indian infants. So these scales are particularly useful in the clinic when you want to really understand as to whether the development has been achieved within a stipulated period of time, or whether there is a decline from a previously attained level of functioning. So with regard to the regression profile of the child, you must understand as to how the regression has happened. So whether there is a history of faltering growth and feeding difficulties, which ultimately lead to the entity referred to as failure to thrive, whether the cognitive domain or the cognitive impairment is in a specific domain such as language, social skills, adaptive behavior, or more specifically in older children, that is beyond 12 years of age, you would be able to judge whether the decline has happened in the memory domain, the executive domain, praxis domain, language domain, or perceptual domain. Whether there is a history of seizures, because encephalopathy, which follows seizures, has different connotations, as we will see further. Whether there is a decline from a previously normal level of functioning, that is with regard to a personality and a behavior change. And then comes the neurological systems. The neurological history should be focused on determining as to whether the neurological deficits which accompany the regression are associated with signs such as spasticity, ataxia, bradykinesia, dystonia, or myopathic features. I'll not be going into details of peripheral neuropathy and myopathy because these are element syndromes which are associated with motor regression, and I will be concentrating mostly on the cognitive and the language regression. One particularly challenging area is the area of autistic regression. Now, autistic regression basically refers to the decline in language as well as social skills along with certain stereotypies. But please note that certain neurological conditions, the children can experience such a profound decline leading to double incontinence, loss of social skills, as well as loss of expressive or receptive language disorders, which is often referred to or connotated as childhood disintegrative disorder. And some of the neurological disorders are primarily gray matter disorders which present with autistic regression, and these include disorders like mucopolysaccharidosis, as well as certain inborn errors of metabolism such as creatine deficiency disorders. But certain genetic conditions, as you are aware of Rett syndrome and Rett-like phenotypes like CDKL5 and FOXG1, those can present with autistic regression syndromes on a background history of seizures. But more importantly, you have a certain subset of conditions directly linked to epilepsy, that is developmental epileptic encephalopathies, the recognition of which and early treatment of which can reverse the autistic regression pattern. It is also important on history that you determine the temporal profile of involvement. So whether the onset of symptoms was acute. In acute, you would obviously think of acquired brain conditions as seen in the MRI of this child who presented to us with a history of neonatal seizures, subsequent normal development, followed by a short 2-week history of visual decline and gait ataxia, followed by a multifocal myoclonus. And this child had a prominent cafe au lait spots, and on MRI, as you can see, has evidence of an infiltrative posterior fossa glioma with an obstructive hydrocephalus. So this is how an acute to subacute presentation in a child who was essentially developmentally normal was noted in our clinic. On the other hand, you have a child who experiences only exclusive scholastic decline from a previously good level of functioning. You do an EEG, you encounter something which is referred to as the periodic complexes. You would immediately start thinking of the entity known as subacute sclerosing panencephalitis. You know that many of the genetic as well as certain conditions which have a genetic basis, which include inborn errors of metabolism, can present to you in a subacute to a chronic progressive course. So they might have an insidious onset and a gradual progressive course. And these conditions include the inborn errors of metabolisms as well as mitochondrial disorders, which can present to you either at a subacute or in a chronic insidious progressive manner. Also, you have entities which do not have a definitive basis. It is not very clear as to whether these are infectious or autoimmune. And these include entities such as the febrile illness-related epilepsy syndrome or FIRES, wherein children can present to you in a devastating manner as new onset refractory status epilepticus, followed by developmental decline. It is extremely important to you that you know the age at onset of these symptoms, because many of the metabolic disorders, as we will see, are connotated by certain ages of presentation, whereas certain metabolic disorders, such as the mitochondrial disorders, have a variable age of presentation. I'm not going into the list. This is exhaustive. It is there in your handout. You basically can classify whether the patient has a metabolic disorder, and on examination, if the child has evidence of visceromegaly, you can decide as to whether the patient is likely to have a storage disorder or an isolated gray or white matter disease with accompanying features. Similarly, you have older children, such as who present between 5 to 15 years of age. You would think of entities such as mitochondrial disorders, Wilson's disease, neuronal cerebral lipofuscinosis, Lafora body disease, as well as white matter disorders. So this depends upon what your examination findings are, but please note that the temporal profile as well as age of onset are equally important for you to determine what your etiological approach would be. As I was mentioning earlier, without going into details of inborn errors of metabolism, depending upon the age at onset of the symptomatology, development of encephalopathy or developmental arrest, you can decide as to whether the patient has what kind of substrate which is likely to be responsible for the metabolic disorder. So children who present in the neonatal period with encephalopathy and seizures, you can think of entities such as non-ketotic hyperglycemia, sulfite oxidase deficiency, or pyridoxine-dependent epilepsy, whereas patients who present throughout the age range of spectrum can have a mitochondrial disorder, and often amino acid intoxications also, well, or organic acidureas or urea cycle defects present within the first month and tend to undergo a plateau and can present variably up to 1 year. Disorders such as lysosomal storage disorders often appear after the age of 1 year, and this is usually in association with visceromegaly. So your physical examination is important with regard to your anthropometry as to determining whether the patient is gaining in excess or losing in excess with regard to the height, weight, or head circumference. So faltering growth could be a sign of regression, and failure to thrive is nothing but the decelerated or arrested physical growth, which is usually associated with abnormal growth and development. And this is usually based precisely on height and weight measurements which fall below the 3rd or the 5th centile, or a downward change in growth across 2 major growth percentiles. So if you chart it on your Denver developmental screening test and follow the child longitudinally, you would actually be able to appreciate the decline in the anthropometry. Your physical examination, I need not overemphasize the fact that, for example, if you have microcephaly as determined on head circumference measurement, it could be, if it is of a fairly acute to subacute onset, you realize that the patient could have an underlying hydrocephalus, or it could be due to a storage disorder as seen in this child with mucopolysaccharidosis, who also demonstrated typical MRI findings with cortical subcortical cysts, in addition to X-ray vertebral abnormalities showing the beaking of the vertebra. Physical examination is also important with regard to determination of skin as well as hair abnormalities. You can see here that this child who presented to us with non-scarring alopecia and later on went on to develop loss of milestones with infantile spasms had biotinidase deficiency, and early institution of biotin actually led to an improvement. This child with failure to thrive had a typical appearance which is referred to as sparse thin hair with pilar tortoise or with hypopigmented hair, had evidence of Menkes disease. Then this patient on the right side showed evidence of a Zellweger syndrome with the typical frontal bossing as well as hypoplastic supraorbital ridges with facial dysmorphism and puff cheek appearance. And this child who had dyskeratosis along with facial dysmorphism had a combination of a gray and white matter disease with a peripheral neuropathy and was detected to have a mutation. The figure on the left shows you a child who has evidence of a mucopolysaccharidosis. You can see the very prominent microcephaly with the prominent eyebrows as well as the prominent jaw features. And you can see that this child had evidence of a mucopolysaccharidosis. I need not overemphasize the importance of determining on history what is the abnormal color of urine or whether the urine has an abnormal odor. Skin changes can also be useful. And on fundus examination, if you can detect evidence of a cherry red spot, you know for sure that you're dealing with an entity, for example, GM2 gangliosidosis, that is Tay-Sachs disease or Niemann-Pick's disease. I would also like to tell you briefly that, epilepsy can present with neuroregression because certain children may have this entity which is referred to as the developmental epileptic encephalopathy, where the regression in multiple domains may be because or maybe a consequence of the epileptic activity which is seen on the EEG, or because of frequent seizures, or maybe a consequence of the etiology, which may have an underlying genetic basis, in which case it is referred to as the developmental encephalopathy because the developmental delay which preceded the onset of epilepsy was due to the underlying etiology. So you have certain epilepsy syndromes. I would just like to emphasize to you, for example, if you have a previously normal child who presents to you with nocturnal seizures, EEG shows features of a continuous spike and wave pattern during slow wave sleep, you know that this is epilepsy due to CSWS and you need to initiate treatment at the earliest. On the other hand, if the child had a prior developmental delay and a diagnosis of a Lennox-Gastaut syndrome, then later on presents to you with a further regression, do an EEG to rule out something like an atypical absence non-convulsive status epilepticus, because early initiation of treatment can return back the child to the baseline. Certain epilepsies, such as the ring 20 chromosome epilepsy, patients can present to you as de novo non-convulsive status epilepticus with loss of language and social skills, primarily because they seem to be out of touch with the surroundings, and a genetic etiology such as ring 20 epilepsy can be detected. There are so many neurodegenerative conditions based on the age of onset, and many of these are metabolic disorders for which I don't want to go into the details. But please note that certain genetic conditions, if identified early, can lead to precision medicine therapies, as has been identified in various inborn errors associated with epilepsy, as well as specific ion channelopathies such as SCN1A, SCN2A, as well as certain other genetic variants such as the GRIN2A and the KCNT1, etc., all of which can lead to precision medicine-based interventions which can improve the outcome in these children. On the neurological examination, you need to determine the extent of encephalopathy, whether the child has an abnormal startle, which can be because of an anoxic injury or because of a progressive disorder such as GM2 gangliosidosis, whether the patient has active seizures which are refractory to conventional AEDs. And on neurological examination, you need to determine whether the patient has a movement disorder, a pyramidal involvement, or an ataxia, or element features in the form of myopathy, peripheral neuropathy, gaze paresis, or cranial neuropathies, or whether the patient has presented to you with an exclusive social decline with psychiatric manifestations. So the core questions that you often answer after the end of your history and neurological examination is to whether you're dealing with a CNS involvement or a peripheral nervous system involvement or a mixed pattern of involvement. If there is a combination of global regression with nerve or muscle involvement, you often think of white matter disorders, mitochondrial disorders, and lysosomal disorders. And then accompanied by the pattern recognition that you see from your MRI, you determine whether the involvement is a gray matter disease, it's a white matter disease, or a combination. So the figure on the left shows you an MRI of a patient with Zellweger disease who has a combination of gray matter involvement with perisylvian polymicrogyria with leukoencephalopathy. And on the right shows you the MRI of a patient with gray matter disease involving the deep nuclei, primarily due to an organic aciduria with typical diffusion restriction signals noted in the basal ganglia. So what are the signs of a gray matter disease? Personality changes, seizures, cognitive regression, and in older children, often dementia. White matter disease, usually focal neurological deficits, pyramidal signs, spasticity, visual impairment. Seizures can be an association, but are conventionally not refractory to anti-epileptic agents in majority of the cases. And primarily, the syndrome is dominated by the motor system involvement, the form of spasticity, and the visual impairment in accompaniment with the cognitive decline. I'll not be going into the details of an investigative approach, but the figure on the right shows you predominantly what an ideal approach should be to a child who has presented to you with a developmental epileptic encephalopathy or cognitive decline following seizures. So after you do your clinical assessment and pattern recognition based on your MRI, if the child is highly refractory, you give a trial of pyridoxine or biotin or folinic acid, especially if the child is presenting to you within the first 3 months of life. And then you go in for the detailed biochemical evaluation. And in infants, you often go ahead with the CSF evaluation, primarily for rolling out CSF hypoglycorrhea, as well as CSF neurotransmitter and bioamine assays. Based on these supportive evidences, which are very useful for the process of endophenotyping, you go in for the genetic evaluation. If the patient has prominent facial dysmorphism, you go in for a karyotyping or with a confirmatory FISH, or directly proceed for a microarray. Karyotyping will obviously pick up abnormalities such as trisomies and ring 20s, whereas microarray may be necessary to detect duplications and deletions. And then if your patient is negative or you don't have the financial capability to do both these investigations, you are often encouraged to go in for a targeted next generation sequencing with an epilepsy gene panel. Please remember that the number of genes that you use in the panel is extremely important. Also, once you identify a variant, it is important that a classification schema be followed to determine as to whether this is a pathogenic or likely pathogenic variant. And it is important also that the variant is confirmed by Sanger sequencing. If your genetic testing is negative, and if you still have a high suspicion of a disorder such as GLUT1 deficiency or a Dravet syndrome, you can go in for a MLPA analysis. If all this is still negative and you have even ruled out a mitochondrial with the help of your mitochondrial genetic testing, whether mitochondrial genes are involved or not, you might have to go in for more invasive tests such as muscle and skin biopsy for disorders such as PME, storage disorders, and mitochondrial disorder. But we are entering into the era of whole exome sequencing and whole genome sequencing, and that approach is still available in the research domain, but is still prohibitively expensive. I need not emphasize to you the importance of EEG in patients with developmental epileptic encephalopathy as well as scholastic decline in order to determine as to whether there is a fragment of epileptic encephalopathy which may be responsible for scholastic decline. Just to show you two examples, on the left is a figure with a patient with autoimmune encephalitis who presented to us with features suggestive of MELAS, but was later on diagnosed to have anti-NMDA receptor encephalitis despite an initial negative CSF, and responded subsequently to intensive immunotherapy. And on the right, I am basically showing you the example of a patient who presented to us with a PME syndrome, with MRI showing you typically thin corpus callosum and EEG showing you features of an epileptic encephalopathy, with skin biopsy only on electron microscopy showing you concentric zebra bodies, which was suggestive of the diagnosis of mucolipidosis. So this is basically an exhaustive list of do not miss list of treatable IEM, because if these are identified early initiation of either substrate replacement or alternative supplementation, for example, ketogenic diet used in GLUT1 deficiency, can actually improve the outcome and normalize the developmental trajectory of children who have experienced a regression. And primarily, if you're looking at older children, just as you associate dementia versus dementia plus, you go in for cognitive dysfunction or encephalopathy with plus features or not. So the plus features can be extrapyramidal features, pyramidal features, epilepsy, gaze palsy, ataxia, peripheral neuropathy, or psychosis, or maybe a combination of these features. And each of these may have a different connotation. Please go through the list in the interest of time. But also in the era of genetic testing, it is important to realize that genotype-phenotype correlations are highly relevant. So if a child presents to you with, say, a movement disorder with epilepsy or seizures, you would think of an entity such as SCN1A, in which the patients can develop Parkinsonism. Or if the child has typical figure of 8 stereotypies, you would think of an entity such as STXPP1. If the child has evidence of myoclonus ataxia, you would think of progressive myoclonus epilepsy due to CLN mutations. If on the other hand, the patient has a fairly subacute to acute onset, which is often precipitated by fever or trauma, along with development of supranuclear gaze palsy, with progression of Parkinsonism, which is in a rostrocaudal distribution, and with no response to levodopa, you would think of ATP1A3 mutations. If the patient has exclusive supranuclear gaze palsy, you might with facial dystonia and pyramidal signs, you would think of the entity of Kufarakip syndrome, which is due to ATP138 mutations. So in the era of genetic testing, it is important that your endophenotyping be particularly robust to determine as to what is the correlation between your genetic result and with the phenotype of the child, because this is what you're going to finally communicate to the patient with regard, and the patient's family with regard to the expected outcome. And this would also drive your therapeutic intervention. So, for example, if you have a patient with, let us say, a subacute onset of dystonia with supranuclear gaze palsy, in an infant who presents at less than 2 years of age, you would initially think of supplementing levodopa, because this could be a neurotransmitter disorder secondary to, say, sepiapterin reductase deficiency or PTS deficiency, or aromatic acid decarboxylase deficiency, which may be responsive to levodopa or pyridoxine. So this kind of genotype-phenotype correlations are extremely important when you are trying to establish the correlation between what the result of your genetic test is and what your examination findings are, because unless your endophenotyping is robust, you are not in a position to interpret these results. On this note, I would like to end my talk. Thank you.
Fantastic. I think you covered such a vast topic in such a short span of time, Ramshekar, and that too in such a thorough way. Very nice. I think I was very impressed. And I myself learned so many points out of this single lecture. Thank you very much, Dr. Menon. Thank you. Manasi, do you want to share this thing for a minute? The Thursday? Hello. So this Thursday, just a reminder, we have a long case presentation. We have a case of subacute hip girdle weakness, and Dr. Satish Khadilkar, who is going to take your case session. So please take advantage of this Thursday clinic. Let's move on to our next lecture. Another very important topic is essentially management of spasticity in cerebral palsy. I suppose it is useful both as a question, as an answer to the question, as well as in day-to-day life, so much so in day-to-day life, because we're going to manage cerebral palsy time and again. So we have Dr. Harpreet Singh, who is a consultant neurologist at Fortis Noida, and he's going to enlighten us on the topic. Off to you, sir. You can begin.
Am I audible, sir?
Yes, you're very
yes. I'll just share my screen. Many thanks for the invite, sir. And I'm really glad for this talk. Wait a minute, please. Let me just check. Yes, sir. Yeah. Can you see my slide, sir?
Yes, we can begin.
Oh, just I think.
Yeah,
Okay,
that's
sir. Thanks a lot for the invite, sir, and I'm really glad I could help you in this. And it was a really good experience for me also to learn to read something new. So I focused a bit on orthopedics aspect, which was I think which most of us don't know much about exactly how they help in cerebral palsy. So straight away going into my topic. So basically, it is surgical and medical management of cerebral palsy. So it's basically a group of permanent but not unchanging disorders of movement or posture or kind of motor function, which are due to non-progressive interference or a lesion or an abnormality of the early stages of the developing brain. It is also called as a static encephalopathy, which means it is mostly a one-time insult to the brain. And it's a quite a wide term, has varied etiologies as such. So it's the most common motor disability of the childhood. Exact prevalence incidence is not known. It's not very clear. However, in US, around 7 lakh children are affected with this disorder, and every year 2 to 5 newborns are affected out of per thousand. World, there are not much data available. However, 1.5 to up to 4 per thousand live births are affected by this disorder. So, what are the causes of cerebral palsy? Most common actually is prenatal causes. I'll just elaborate little in the next slide. However, you have congenital causes like malformation of cortical development, such as hydranencephaly or hydrocephalus or other non-cerebral malformation, which can also contribute to this. Genetic children in newborns who are monozygotic twins, they're at a higher risk. And if you have a history of consanguinity, it is more common in those. And if there are some dysmorphic features, you have to go for chromosome analysis, means some genetic cause may be there. Inflammatory causes can be there. Infectious, most common reported in literature are CMV and Epstein-Barr virus. However, sometimes bacterial UTI is known to cause. However, COVID, which has come in this era in the last 1 year, so long-term results are not there, and I think very few people have delivered during this time who had actually had COVID during pregnancy. So the results I think may come in a year or two, and you see is this any abnormality coming in the child or not. Then we have very common syndromes of anoxic, that is HI, hypoxic ischemic encephalopathy syndrome, most commonly grade 2 or grade 3, which have seizures also along with them. Traumatic, any history of birth injury or any trauma causing ICH or any other abnormality in the brain. Last but not the least, metabolic, which includes urocycle disorders and mitochondrial. Now, what are the risk factors for cerebral palsy? The most common is prenatal, especially prematurity and preterm babies. So they're at most maximum risk for this cerebral palsy. Perinatal, you have chorioamnionitis, HIE, difficult labor because of breech or any other cause or non-vertex presentation. Postnatally, I think we are all well aware of connectors, which is a very typical cause of dystonic cerebral palsy. Then you have infections which can come postnatally, like uh, childhood or neonatal meningitis, which can sometimes cause cerebral palsy. Then you have intracerebral hemorrhage or trauma in the early neonatal or in the infantile period, which can cause cerebral palsy. The main types which are most common is spastic, which is around 80% of the patients included in this group of CP. Next is ethetoid or dystonic cerebral palsy, which affect around 10 to 15% of patients. Last but not the least, and the least common is ataxic, which affects the cerebellar portion. So I think this figure, I think if you can just remember, you have a regional involvement in which you have hemiplegia and diplegia. So diplegia means affection of lower limbs more than the upper limbs. So it's basically a regional involvement. Then you have global body or total body involvement, which includes one type of spastic, which is quadriplegia, Then you have ethetoid, dystonic, and ataxic. So then you come to the spastic, dyskinetic, and ataxic type. So spastic is basically because of gray matter involvement, either of one hemisphere, mainly the upper limbs and the lower limb involvement. Diplegia, when you have basically more of lower limb involvement, and then you have quadriceps when you have both the upper as well as lower, which are equally affected. Dyskinetic, you have basic involvement of deep gray matter like thalamus and basal ganglia. Ataxic is involvement of the cerebellum. So coming to the management, so the basic goal of management is not to cure or to achieve normalcy, but to increase functionality so that the child can come to the normal mainstream as much as he can. So he's independent for all his activities of daily living to improve his capabilities, sustain health in terms of locomotion, cognitive development, social interaction, and independence. So you have to intervene early with intensive management. And it's always a team approach in cerebral palsy because a lot of disabilities there in terms of spasticity, dystonia, joint issues, bed-bound state, bed sores. So those can contribute to the worsening of the condition, or in fact not coming to the mainstream or not coming into the normal social life. So you have a primary doctor who possibly is the head who actually guides the patients to which of places to go. Then you have physiatrist who is very important in terms of exact physiotherapy management. You have an ortho surgeon coming into picture. You have a physiotherapist or occupational therapist and a neurosurgeon if you want to go for further treatments in terms of surgery. So medical treatments, it is basically management of abnormal movements, and that those movements can include dystonia, ethetosis, myoclonus, chorea, and the most important is spasticity. Now in spasticity, we have one indication of Botox or Dysport. That is the first botulinum toxin which was actually approved by FDA, and it was given treatment for lower limb spasticity in children from the age of 2 to 17 years. So it was based on RCT multicentral double-blind study, which actually included 235 patients, out of which 150 were pediatric patients who had received Botox, 77 had received placebo. So there was an improvement in modified Ashworth scale at 4 weeks and 12 weeks. Hence, the approval came into picture that it is effective for focal or segmental spasticity. However, Botox or the ONA botulinum toxin A can also reduce spasticity for 3 to 6 months and may be considered for off-label use in children with cerebral palsy with specific lower limb, especially gastrocnemius. The established total dose is limited to 12 units per kg. However, it can go up to 20 units maximum to the tune of 600 units. And exceeding not more than 400 per units per visit. And in this, each muscle receives 1 to 2 units per kg. Large muscles can go up to 4 to 6 units per kg. And the interval, I think all of us know, should be at least 4 months to prevent antibody formation. However, the dose of Dysport is 1 to 5 times of Botox. So some people use 3, some people 5, some people they take the same value 1 and 1. However, 3 to 5 I think is the most preferred one. 3 is the best thing. So if you give 1 unit of Botox, 3 units of Dysport. Next is phenol intramuscular neurolysis, which is not very commonly used, but some large muscles or several muscles are treated at the same time in this sort of therapy. It's more difficult and anesthesia is required for this treatment. You use a nerve stimulator and it can sometimes result in sensory dysesthesias. It's more commonly used for motor nerves, especially for musculocutaneous, obturator, and hamstring muscles are classically used. Coming to oral medication for spasticity, commonly used medication what we use are baclofen, diazepam, clonazepam, dantrolene, and tizanidine. I think most of us commonly use baclofen and tizanidine, and rarely diazepam or clonazepam. And the problem with oral medication is that the effects will be systemic rather than focal. So you have to be very, very careful in terms of side effects of these medications when you start giving to the patient. Tizanidine, diazepam, it can be used in severe spasticity, increase GABA at spinal and supraspinal sites. However, it is effective in seizures also. So you can also add in patients who have got seizure along with this. It's quite rapidly absorbed orally. Metabolism in renal and hepatic. Side effects are mainly sedation and sometimes can worsen swallowing issues in children. Tizanidine, it is more centrally acting. It is imidazoline derivative and a central alpha-2 noradrenergic agonist. It acts mainly by H reflex inhibition, which is an antispastic effect, and it increases the negative effect of glycine or inhibitory effect of glycine, hence by decreasing substance P and excitatory amino acids, metabolized in liver and urine and feces. Next is baclofen. It's basically a GABA analog that inhibits calcium influx into presynaptic terminals and suppresses the release of excitatory neurotransmitters. It causes hyperpolarization at the monosynaptic and polysynaptic terminals at the spinal level. Primarily excreted by kidneys, but partially metabolized by liver. Also works better in treatment of spinal spasticity. So that is a very important point. Cerebral palsy is basically a disease of the central nervous system. So this can work in cerebral spasticity, but best works in spinal spasticity. And CNS side effects in terms of sedation actually limits its use. Now, American Academy of Neurology and Child Neurology Society, it recommends use of Botox, and Dysport is effective with black box warning in terms of side effects for localized or segmental spasticity. However, for generalized spasticity, diazepam is possibly effective. Tizanidine is probably effective. So it is better than baclofen and tizanidine. Now, if the patient has got some other symptoms along with this in terms of dystonia, seizures and myoclonus, choreoathetosis, you can add the drugs as per the symptoms of the patient at that time. Now, coming to surgical treatments for spasticity, the main involvement comes from the neurosurgical team and the orthopedic surgeon or the orthopedic team. Now, neurosurgical treatment is basically intrathecal pump, baclofen pump insertion. Second is selective dorsal rhizotomy and stereotactic basal ganglia stimulation. So in this intrathecal, it is quite useful in patients with diffuse spasticity or dystonia. However, it is very useful to decrease spasticity in the lower extremities and trunk. However, in upper limbs, the role is limited because usually you put this pump actually in around the conus cauda area. So for that injection or the baclofen to go to the upper thoracic or the cervical vertebra, it's a very long distance for that, and moreover it will spread more to the lower region. So if you want to involve the upper limbs or to make improvement in upper limbs, you have to insert a little higher level, not at the conus level. So it allows more local presynaptic inhibition of 1A sensory afferents and has fewer adverse effects than oral. And it is being used nowadays commonly, but in between I think it was not available in India. So now I think it has again come back. So we have also used in very few patients, not many. However, there was good improvement in some patients, not all. And this refilling can be done by the company which gave baclofen. And the dose can be adjusted by you or the surgeon or by the company, how much dose you want for that patient. Next is selective dorsal rhizotomy. It may be beneficial in both short-term and long-term management of spasticity. Laminectomy and then surgical ablation in around 90% of dorsal or sensory nerve root 1A fibers is done by the surgeon. It basically decreases spasticity by decreasing reflexive mononeuron activation, which is thought to result from the lack of descending fiber input. So you have to select carefully such patients. It can sometimes cause weakness at that level of the surgery, and when you have a weakness, spasticity per se actually helps the patient to walk. So when you cause that weakness, sometimes it can worsen in terms of functional independence. Nowadays, most surgeons do not prefer selective, they selective, super selective. Just at 1 or 2 levels, they can do smaller laminectomies to prevent any major side effects in terms of loss of spasticity. Now, next is stereotactic basal ganglia stimulation. Data is limited for this. It can improve rigidity, choreoathetosis, and tremor. There was a meta-analysis published in 2017, which found some variable results depending upon the severity of dystonia and presence of either minimal or spasticity or ataxia. And they found that that there needs to be better markers to define the appropriate candidate for such radical stereotactic basal ganglia stimulation. Now, next is orthopedic surgery. So you have to time your orthopedic intervention when you know the CNS has totally matured, you know the ambulation potential of your patient, and you have seen the rate at which the contracture or the liver arm dysfunction is developing. Now, in orthopedic surgery, absolute indication is significant hip displacement. Otherwise, there is no absolute indication except for this. So in the absence of hip displacement, one school of thought says that you can delay any orthopedic surgery till the age of 7 to 9 years because of high risk of recurrence once you operate. The second school of thought says that the best functional outcomes are achieved between the 4 to 6 years. So there is some controversy and different schools of thought. However, I think 5 or 6 years should be good enough age for a child who has developed some contractures or some hip issues or some knee issues. So in spastic diplegia, the formal and intensive orthopedic surgery treatment should be completed between the age of 4 to 8 years, because they say mature patterns are usually by the age of 4 years, at the max by the age of 7 years. So I think 6 to 7 or maybe 5 to 7 years will be a good age for any intervention from the orthopedic team. Now, the goals of this therapy is to reduce spasticity in a selective manner, because the increased muscle tone, which I told you, can sometimes be helpful for the patient. You have to correct contractures which are actually hindering the function or interfering with the hygiene of the child. You have to simplify his control system in terms of walking. You have to preserve the power generators like your adductors or the abductors of the thigh or the quadriceps, and all those have to be preserved. And you have to correct the liver arm dysfunction and subluxation or dislocation of the joints in terms which is most commonly with hips. So when you start treating such patient, the first decade of life means you have to give for the function for the child. Function means how much independent he is. Second, you give for the second decade, you give importance for the appearance, how the child is looking, good or bad, or how many contractures you have, or where and all you have issues in terms of uh, appearance for the child. Third, and the subsequent decades, you have to avoid pain as much as possible. So it should be goal oriented, planned, anticipated, and focus on the projected outcome and the quality of life. And you must not be used as a last resort. You have to intervene early, preferably by the age of 5 or 6 years. Now, common surgeries which they undertake is most commonly it is being done in lower limbs. Foot and ankle is the most common area which is affected, and most common area you actually operate or the orthopedic team operates. The most common deformities are equinus, equinoplanovalgus, and equinocavovarus. Now, in equinus, actually, it's basically caused by the involvement of gastro and soleus. So in diplegia, you only operate on gastro from mid calf tendon release. However, when you have hemiplegia, you have to go a little more distal, in which you operate on both gastro and soleus. Now hip. Now, hip displacement, up to 90% of children can have hip involvement and displacement, and hence the child can develop coxa valga, femoral anteversion, acetabular dysplasia, excessive flexion adduction, which can actually eventually lead to hip subluxation and finally dislocation in around 60% of patients by the age of 7 to 9 years. So that, I think that is the age group which you have to intervene in terms of hip. And why this is required, why you have to see the hip, because it actually affects the personal hygiene and the dressing of the child. It can contribute to femoral fractures, it can contribute to pelvic obliquity, it can cause pressure ulcers, and it can worsen scoliosis, which actually will require further treatments by the orthopedics. Hence, you have to survey the hip every 6 months or 1 year to see for spasticity, how much is affecting the hips. If there is a delayed walking or inability to walk by the age of 2.5 to 3 years, when there is reduced hip abduction, and if there is a concern by the caregiver or the healthcare worker saying that the child is unable to move the limbs at the level of hips. Now, next is knee. Lengthening of the hamstrings can help the knee straighten, so improve the walking pattern. And sometimes you have to transfer a muscle from the front to the back of the knee, which can also help by reducing stiffness around the knee. Now, coming to spine surgery, the incidence of scoliosis is to the tune of around one fourth of patients can have scoliosis. It's highest in patients with spastic CP, and in patients with subluxated or dislocated, it is more common, and patients who are bedbound. So you have to do spinal instrumentation and fusion because of significant curve progression, loss of sitting balance, and to improve the comfort of the child. Now in upper limbs, you have the basic aim is to improve the hand grip or to improve the dexterity as such, so that the child is able to hold on to some things when he is doing physiotherapy or occupational therapy. So the principal goals in surgical reconstruction of spastic upper limb are to improve grasp and release pattern between wrist and the digits, improve the hand appearance, function of the affected hand, and psychological status of the patient and the family. And it also improves the use of assistive devices following lower limb surgery. So when the child is able to stand, but the hands are not, they are spastic or they are having a lot of contractures, so the child will have issue in terms of holding your uh, devices during OT. So the indications for upper limb treatments in terms of orthopedics are spastic and mixed group with mild ethetosis. Sufficient mental condition and emotional stability should be there, so the child is able to understand in terms of therapy post surgery. Okay, what needs to be done, how much I have to cooperate in terms of therapy. When this actually has a low emotional influence on spasticity, you have infantile hemiplegia, especially perinatal, and young patients after the age of 6 to 7 years. Now, there are some other conditions which actually comorbid, which actually go along with this cerebral palsy. One is saliva control. You have to take a help of a speech pathologist, and you can start a small dose of benzoxazole or glycopyrrolate. Second is constipation. You have to use a high fiber diet, and you can use a laxative at that time for the child. And nutrition, you have to take the help of a dietitian, use of a peg or a tube feeding if the child is unable to swallow. Now, I'll just give a very brief, it's not a very big approach, it's a very small. I think you have to take helpful different specialities. You have a child with delayed development, clinical examination done by a pediatrician, child neurologist, or an adult neurologist. You have confirmed it is cerebral palsy with an MRI brain also, and clinically you are saying, okay, it looks like a spastic or a dystonic cerebral palsy or ataxic one. So the one major arm is medical, in which you have treatment of spasticity. Then you have other comorbid conditions which are to be treated along with this by you or the primary physician. Now, if the child is not improving and he is worsening, or he requires any further treatments in terms of uh, generalized spasticity, you can take the help of a neurosurgical team in terms of baclofen pump or any other surgical procedures. Now, you have to keep assessing the child till the age of 4 to 5 years or 6 years. You feel the child is developing any further uh, contractures in lower limbs, or he requires a lengthening procedures, or for any joint involvement to take for ortho surgery. And then you have very major involvement from the rehab team, which includes a physiatrist, a physiotherapist, a speech therapist, and last but not the least, most important is occupational therapy, because they actually play a very major part in smaller kids. Thank you.
Very nice. Thank you, Dr. Singh. Very practical lecture and good for theory as well. Let's move on to our last lecture on mitochondrial disorders with emphasis on mitochondrial myopathy by Dr. Virat Sanghi, who is a neurologist at KEM Hospital, Mumbai. Virat,
Hi, Shripad.
hello.
Yeah, hi, Shripad. Good evening. I'm here.
Good evening. Yes. You
Can I
can
start?
begin.
I can start sharing my screen?
Yes, yes, you can
Okay,
begin.
okay, great. So I'm just going to start. Okay, so good evening to all of you. Gives me great pleasure to be a part of this very good initiative by Fine for students. And at the outset, I think it's a wonderful idea to have a lot of discussions on theory. And I know that Shripad, when he called me up, said that the theory is one aspect of teaching that seems to be neglected these days. So that's when I said, okay, I'll specifically make this talk for all of you today based on your theory paper. And as such, we're going to really focus on very, very theoretical aspects of mitochondrial disease, which I think are very important for both short notes and full questions in your paper. So today, we're going to focus on mitochondrial disorders, especially the mitochondrial myopathies. As all of you are well aware of, these are a group of very heterogeneous genetic disorders. They're heterogeneous both clinically as well as genetically, as you'll see in the few slides to come. Mitochondrial diseases obviously are caused by total or partial dysfunction of mitochondria. And these disorders can affect not only individuals at any age spectrum, right from neonates all the way up to the elderly group, but also they can target any organ in the body. They're truly multi-systemic diseases. It's always very important when you have a short note or a full question to put a little bit of basic science into that answer. So if you have time, do talk a little bit about the mitochondria and what they are. So mitochondria, as you all know, these are very, very important, complex intracellular double membrane organelles. They're present in all nucleated cells. They're the energy factory or the powerhouse of the cell. So you must use these terms in your answer, in your short notes or in your questions. You must write down these terms: energy factory, powerhouse. Examiners would like to hear that. And as you all know, they are very necessary for the generation of ATP through oxidative phosphorylation. So again, this is a very important term for you to use, the OXPHOS reaction. Now, what is this OXPHOS complex, or what is oxidative phosphorylation? So this complex is located on the inner mitochondrial membrane. As we talked about in the previous slide, it's a double cell membrane. So on the inner mitochondrial membrane, you have the OXPHOS location. There are 5 main complexes that you must keep in mind. Complexes 1 to 4 are involved with the mitochondrial respiratory chain. And complex 5 is the ATP synthase pump. So I think this is sufficient for you to know about the OXPHOS complex. I've just illustrated it here for you. You don't have to obviously show this in your exams in the theory answer, but this is just to highlight it and explain what I've been saying a little clearly. If you look at the top hand over here, this is the mitochondria. You can see the double membrane, and you can see that the inner membrane is folded. So this is very characteristic. The inner membrane is folded into what we call as cristae, and these cristae have the OXPHOS complex located on the inner membrane. So if we take this little area here of the inner membrane and we blow it up over here, this is what you will end up seeing. So this is the inner membrane over here. This is the intermembrane space that you see over here. And this is your OXPHOS complex. As we talked about, there are 5 complexes, complexes 1 to 4, which are the respiratory transport chain, and complex 5, which is your ATP synthase chain. Now in the OXPHOS reaction, it's all you have to remember is that energy is transferred as electrons from one complex to the other complex in the presence of oxygen. So this is it's an oxidative process. You need oxygen in order for the OXPHOS process to take place. And you transfer electrons from one complex to the other, and energy is finally created in the form of ATP. So this is what we call as chemical energy, because ATP is being generated within the ATP synthase. So this is very simply put the OXPHOS reaction. Now, mitochondria are not only important for generation of ATP and the OXPHOS reaction, but they're also very important for redox homeostasis, calcium homeostasis, fatty acid oxidation, very important metabolic process as well. They're also important for the biogenesis of heme and iron sulfur proteins. And you may, in some of these disorders of heme and iron metabolism, then get secondary mitochondrial dysfunction, but that's for another day and another topic. These don't come under primary mitochondrial diseases. And mitochondria also play a very important role for apoptosis. And this is just a diagram for you all to use in your exams. So if you do get a full question on mitochondrial diseases, do draw this diagram. It definitely carries a lot of weightage and it's a very simplified representation of what I just showed you. Mitochondrial genetics is extremely important to understand, both from your theory paper, but also from a clinical perspective. It's a very practical, very clinical topic these days, and something that all of you must understand. The human mitochondrial genome is a circular double-stranded DNA molecule. So if I just quickly go back and show you over here in this diagram, you can see that this is what the DNA is. I mean, if it's just a very simplified basic thing. You can see it over here, even more simplified over here as a circular complex. So you just have to remember that mitochondrial DNA is a circular molecule. So, all right, so it's a circular double-stranded DNA molecule. The mitochondrial DNA encodes for only 37 proteins within the mitochondria. Keep in mind that there are 1,500 proteins involved in mitochondrial metabolism, and only 37 proteins of these 1,500 are encoded for by mitochondrial DNA. The rest of these 1,500 proteins are encoded by nuclear DNA. And this is very important to keep in mind, that only 37 proteins are encoded by mitochondrial DNA. Of these 37, 13 encode the respiratory chain proteins, and the balance 29 are involved in machinery for translation and transcription within the cell. Within the mitochondria, sorry, not within the cell, but within the mitochondria. Now, primary mitochondrial diseases can be caused by mutations either in the mitochondrial DNA or the nuclear DNA. And that's what we spoke about in the previous slide, that out of the 1,500 proteins in the cell, within the mitochondria, for the mitochondrial metabolism, only 37 of these are controlled by mitochondrial DNA. The remaining protein function within the mitochondria is controlled by nuclear DNA. And therefore, mutations even in these nuclear DNA can cause mitochondrial diseases. And so far, there are approximately 350 genetically distinct diseases or genetic mutations that have been identified to produce mitochondrial disorders. This slide basically shows you the different pathogenesis. On one hand, you have mitochondrial DNA mutations, which would lead straight away to either by point mutations or by deletions and duplications, leading directly to mitochondrial dysfunction and therefore mitochondrial disease. And on the other side, you see the nuclear DNA mutations, which through various processes can give rise to mitochondrial dysfunction and eventually mitochondrial disease. Now, this is important to keep in mind. Obviously, if you have a mitochondrial DNA deletion, duplication, and mutation, you know that the mitochondrial DNA is maternally inherited, therefore passed on from mother to offspring. And therefore, the maternal inheritance pattern is for mitochondrial DNA variants. And for the nuclear DNA variants or mutations, obviously, you can follow the nuclear DNA inheritance patterns, which can either be autosomal dominant, autosomal recessive, or X-linked inheritance patterns. In a large number of patients with mitochondrial diseases, we do see sporadic or de novo mutations coming about where the family history will be negative. So a negative family history doesn't rule out a mitochondrial disorder, and certainly disorders that have an inheritance of either AD or AR or X-linked do not mean that they cannot be mitochondrial. The classic teaching has always been, oh, mitochondrial disease, it has to be maternally inherited. But as you've seen, that's not true, because the vast majority of mitochondrial genes comes actually from the nuclear DNA mutations. So keep that in mind, and they can also be sporadic or de novo. So mitochondrial disorders can really affect any organ or tissue in the body, but most commonly those that are involved with very high energy requirements and are highly dependent on aerobic metabolism are the ones that are most likely to develop pathology or mitochondrial pathology. And this includes, of course, the CNS, the cardiac muscle, and the skeletal muscle. Liver and kidney are also involved. So from the perspective of a neurologist, what are the common ways in which these can manifest? Obviously, vision loss, ophthalmoplegia, ptosis, deafness, sensory neural deafness, that is, hypotonia, epilepsy, headaches, strokes, peripheral neuropathies, myopathies, global developmental delay, intellectual disability, and even the autism spectrum disorder. So really, you can see that the mitochondrial manifestations are very, very varied, and they spread across all axes of the neurological system. So literally from seizures and strokes right down to the peripheral nerve, muscle, you can get a vast, vast spectrum of disorders and clinical manifestations. So what are the mitochondrial syndromes? So what we've done over here is enlist the mitochondrial, those common syndromes that are caused by mitochondrial DNA mutations on the left-hand side of your screen, and the common nuclear DNA manifestations on the right hand of your screen. So the common mitochondrial DNA syndromes that you've heard of, CPEO and Kearns-Sayre syndrome, which we'll talk about shortly, Leber hereditary optic neuropathy, NARP, MELAS, and MERF. And on the other hand, for the nuclear DNA syndromes, there's the Polgy-related disorders, Leigh disease, coenzyme Q10 deficiency, Alpers, Mingy, pyruvate dehydrogenase complex deficiency, and pyruvate carboxylase deficiency. So these are the most common mitochondrial syndromes that you need to know about. Just a very quick word, the Polgy-related disorders have come into a lot of kind of limelight in the recent years, and a lot of people now talk about Polgy-related disorders. Again, there's a vast kind of range of clinical presentation of Polgy-related disorders, starting from the neonatal or infantile ages, going right up to young adulthood for different manifestations. And you can either present these patients may present in neonatal or the infantile period with a cerebro-hepato-myopathic spectrum kind of picture, or myocerebrohepatopathy, MCHS. Later on, you may have an Alpers syndrome. And then as you go into the teens, you can even develop varying combinations of ataxia, neuropathy, myoclonic epilepsy, spinocerebellar ataxias. So there's a huge spectrum of Polgy-related disorders and very varied presentation of Polgy, and a lot of, especially with the explosion of genetic work that we're all doing and seeing in the clinics, there's more and more of Polgy-related disorders that's coming to light. So something important for you all to know and also talk about in your exams. So a lot of emphasis now on mitochondrial myopathies. So these are disorders where myopathy may be the only clinical feature of the mitochondrial disease, but more commonly, the myopathy is usually associated with a few additional mitochondrial manifestations, or what we call as the mitochondrial red flag manifestations. And as we spoke about those a little earlier, these could be diabetes, it could be deafness, it could be optic atrophy, peripheral neuropathy, you may have an associated cardiomyopathy, liver disease, kidney disease, stroke-like episodes, seizures. So any of the other mitochondrial red flag manifestations may be associated with these myopathies, but myopathies are usually the predominant feature of these mitochondrial myopathy disorders. And these are defined, therefore, as primary mitochondrial myopathies. They are a group of genetically defined disorders. And basically, what we see is a disruption of the OXPHOS pathway that we spoke about earlier that affects the skeletal musculature. But as I said, it's predominantly a disorder of the skeletal musculature, but not exclusively that of skeletal musculature. And you may get other parts of the neuroaxis involved in these disorders, or you may even get other systemic involvement with these disorders. So the first disorder that we would like to talk about, and the most common mitochondrial myopathy that we know, is chronic progressive external ophthalmoplegia, or CPEO, now known also as PEO, just progressive external ophthalmoplegia. As the name suggests, it's slowly progressive. It's usually bilateral. There is, of course, ophthalmoplegia, as the name suggests. There is restriction of eye movements in all directions. It's very slowly progressive to the extent that the patient may just have completely fixed eyeballs by the time they present. Occasionally, they may have diplopia. So diplopia is not common in these patients. A, because it's very slowly progressive, and B, it's usually symmetric. However, if you have an asymmetric ophthalmoplegia, then these patients may occasionally complain of diplopia, but that's not usual. Keep in mind that the intrinsic ocular muscles are not involved, and therefore it's called as progressive external ophthalmoplegia. Bilateral ptosis is common in these patients, and you will often note the compensatory frontalis hyperactivity that is seen. And many of these patients will even be chronically tilting their head a little backwards so that they can see better, as they would with any other cause of bilateral ptosis. A limb girdle myopathy, which is proximal muscle weakness of the upper limbs as well as lower limbs, is prominent in these patients. So typical features: getting up from the floor is difficult, a waddling gait may be seen, difficulty in raising their arms above the shoulders. They'll also have an axial myopathy. So neck flexor weakness can be quite common. Some patients may even have neck extensor muscle weakness. So both flexors and extensors may be involved, but more commonly the flexors are involved. And keep in mind that these are very slowly progressive disorders. They're symmetric, as I said, and you may see variable muscle wasting. Later on in the course of the disease, you may also get oropharyngeal weakness, so severe dysphagia developing, as well as respiratory failure. So CPEO doesn't necessarily just involve the ophthalmic muscles. It may also involve the oropharyngeal muscles, and that's an important thing to keep in mind, because dysarthria and dysphagia can be severe complications leading to even aspiration, as well as intrinsic weakness of the respiratory muscles as well. It's caused by single large-scale deletions of mitochondrial DNA, and it could be either inherited as an autosomal dominant disorder, autosomal recessive, or it could even be sporadic or maternally inherited. So there are various ways in which it can be inherited. Kearns-Sayre syndrome is the next big syndrome that causes a predominant myopathy. So how do we define Kearns-Sayre syndrome clinically? So Kearns-Sayre syndrome clinically is defined by an early onset of progressive external ophthalmoplegia before the age of 20, associated with a pigmentary retinopathy. So the combination of two is a definite inclusion. You must have both of these features for KSS. And with any one of these following clinical features, so presence of a cerebellar ataxia, presence of a cardiac conduction block, or an elevated CSF protein more than 100 mg/%. So if you have early onset PEO, pigmentary retinopathy, and any one of these, then you can make a clinical diagnosis of Kearns-Sayre syndrome. It may also be associated commonly with deafness. Bilateral sensorineural deafness is common in KSS, as is short stature. Other endocrine problems may be seen. Diabetes mellitus may be seen as well. These are caused by large deletions of mitochondrial DNA. They're usually heteroplasmic, and the heteroplasmy actually accounts for the variability in the clinical syndrome. So the greater the heteroplasmy, the more severe the features of KSS. It's often a sporadic disease. So Kearns-Sayre syndrome, usually you won't get a positive family history, and it's often sporadic. You must keep that in mind because it's a somatic mutation. It takes place after we have the cell splitting. So remember that. So it's a somatic mutation, and therefore it is usually sporadic. Rarely, you may get point mutations of the mitochondrial DNA. So it may be rarely maternally inherited if there's a point mutation of mitochondrial DNA, or it may be autosomal recessive if you have a nuclear DNA mutation. But those are rare. Then there's another disorder that's called mitochondrial depletion syndrome. And this is associated with an early onset primary mitochondrial myopathy or early onset PMM. There is a severe disorder in which there is mutation of the TK2 gene. It presents very early on with hypotonia, can have a floppy infant or a floppy infant syndrome. So these babies would typically be very floppy, severe head lag. They won't hold their head. They'll have the frog legging, very hypotonic on examination. They fall through your hands. Failure to thrive, respiratory insufficiency, absent reflexes may be present. And of course, they're very severe diseases, as I said, with mortality usually in early childhood. So this is called as a mitochondrial depletion syndrome, mutation of TK2 gene. Now, there are other disorders as well that you should keep in mind for the myopathies. These are cytochrome B deficiency or a coenzyme Q10 deficiency. They can present with myopathic forms, predominant myopathic forms. And this usually is because of decreased energy production. Both cytochrome B as well as coenzyme Q10 play important roles in energy production, and there is resultant increase in lactate as well as depletion of phosphocreatine. And these patients will typically present with myalgia or muscle pains, fatigue. So fatigue is a very, very common symptom in these patients. And you'll get that in the history. They feel very tired. They're not able to exercise for long periods of time. They're not able to walk for long periods of time, climbing a few flights of stairs, and they start feeling a lot of fatigue. Muscle cramps are common in this disorder. Muscle wasting may be seen. And there's a lot of exercise intolerance, which in severe cases can even lead to rhabdomyolysis and myoglobinuria. So keep this in mind as well. So how do we investigate patients with a mitochondrial myopathy? Mitochondrial myopathies, like you do for any of the other mitochondrial diseases, we look at the CPK levels. They may be normal, they may be elevated. Normal levels will not rule out a mitochondrial disorder. Similarly, lactate levels, they may be normal, they may be elevated. Normal levels do not rule out mitochondrial disease. So keep in mind, but both CPK and lactate may be normal in these patients. In fact, often is normal in the kind of a crisis episode. When are they usually elevated? So many of these patients with mitochondrial disease may go into what we call as a metabolic crisis. If they have fevers, if they have infections, they're undergoing surgery, there's severe dehydration, they may undergo, patients with metabolic myopathy, with mitochondrial myopathies or mitochondrial disease may have a metabolic crisis. And often the CPK and lactate levels are then elevated during these periods or episodes of metabolic crises. Otherwise, they may be completely normal. The EMG and nerve conduction studies may show you features of primary myopathy, and you may see myopathic changes. Classic myopathic changes may be seen. You may also get features of a subclinical neuropathy in patients with myopathic disorders. So keep that in mind. You may get a subclinical neuropathy as well because there's widespread multi-system involvement in mitochondrial diseases as well. And of course, muscle biopsy, you all know you get the classic ragged red fibers on the Gomori trichrome stain. And these fibers on special staining are cytochrome C oxidase negative. So you also do Cox staining in these fibers when you ask for a muscle biopsy in patients with suspected mitochondrial disease. You also have to request for a special Cox staining to be done. And the Cox staining is often negative. They are cytochrome C oxidase negative. There's a very interesting paper, and I've written that at the end, actually, done by an Italian group in 2020. And they've actually talked about the development of a biomarker for mitochondrial disease. So as we've seen, CPK and lactate levels are really poor biomarkers to detect mitochondrial disease. They are often normal, actually, in patients with mitochondrial myopathy. This group has actually postulated that the biomarker FGF21 may be a reliable serum biomarker to keep in mind. So it's still in the research stages. It's not available clinically for us, but something that's being developed as a biomarker for mitochondrial disease. And of course, finally, once you've done your workup for patients like the way we've described above, you proceed to do genetic studies, initially starting off with a mitochondrial sequencing. And finally, if you don't get an answer from the mitochondrial sequencing, you proceed to do whole exome sequencing to look for the nuclear DNA mutations we talked about. So the way I would do it is I would first do study the clinical phenotype. Once you look at the clinical phenotype, you know what are the common mutations that lead to that clinical phenotype. Look at those mutations first. If those mutations aren't found, you can go on to do a mitochondrial sequencing or mitochondrial exome sequencing. And if the mitochondrial exome sequencing gives you an answer, great. If not, then you move to do a whole exome sequencing to look for the nuclear DNA variants. This is an example of the muscle biopsy that's done using a Gomori trichrome stain. And the white arrows point to the ragged red fibers that you see, the classic ragged red fibers that you see in a patient with mitochondrial myopathies. So in your exams, you could very quickly draw this out. You don't obviously have to color everything blue, but you could just use a red pen or a colored pen and show these ragged fibers. Very easy to draw. In a couple of minutes, you could get that done and get a few extra marks for showing this diagram. Very easy to draw. Do remember that you also have a lot of fiber variability. So variability in the fiber size and shape, as you can see here. So apart from the ragged red fibers, what you're also seeing is variability in the fiber size and shape. So do show that when you're showing it in your diagram. You'll get additional marks to talk about the fiber variability. And this is a cytochrome C oxidase stain or a COX stain on these fibers. The muscle fibers that are purplish in color are the ones in which you don't have COX. So those are the COX negative fibers. So this is again just an example to show you muscle biopsy, and the purplish color is the ones which are COX negative. Normal fibers should be stained brown. Coming to the treatment, as you're all aware, there is no disease-modifying treatment or cure currently available for mitochondrial diseases. So we don't have any drug that we can say is going to modify the outcome or slow down the progress of the disorder. What we commonly do and prescribe for all our patients is a mitochondrial cocktail, which is nothing but a cocktail of vitamins and supplements. That includes coenzyme Q10, carnitine, riboflavin, thiamine, pyridoxine, and whatnot. The benefits of this are not clinically proven, and there has been no research that demonstrates any benefit in these unless you have a patient who has coenzyme Q10 deficiency. So the genetic coenzyme Q10 deficiency, then supplementing coenzyme Q10 or supplementing idebenone will be of benefit. But in the vast majority of mitochondrial diseases, these don't really have any benefit, but we do prescribe it anyway. There is no proven benefit of any of these. Supportive care is very important in patients with mitochondrial disorders. Obviously, physiotherapy and orthotic devices are extremely important for patients with a myopathy. Respiratory care is extremely important. As you've seen, some of these disorders can be associated with respiratory failure. So good chest PT, suctioning, and in the end stages, even BiPAP machines. These patients must be monitored. Their night or nocturnal SAT levels must be done. Overnight sleep studies must be done. You must look for elevation of carbon dioxide or fallen O2 SATs at night, and put them onto a BiPAP machine if necessary. Care of feeding is very important. We've seen that the patients with CPO can develop feeding disorders, oropharyngeal dysfunctions. So care of nutrition and a PEG, insertion of a PEG is important. Metabolic stress, we spoke about how metabolic crises can occur with infections, dehydration, fever, surgery. So you must supplement or support these patients during times of metabolic stress, give them IV fluids, admit them if necessary, take care of any kind of decompensation or rhabdomyolysis or myoglobinuria that can take place. And of course, there's possibly a role of maybe gene replacement therapy in the future as far as the treatment options are concerned. Just ending today's talk with what I think are some really key papers that I think all of you should read. Apart from textbooks, do get into the habit of reading some of these articles. And I think these 3 articles in particular are really good articles. The first article is the one I spoke to you about. It covers a lot of the basic genetics. And then the last article is the Italian study I spoke about, which actually has talked about the new biomarker for mitochondrial myopathies. So with that, I'll end my talk and wish you all a very good night. Thank you.
Thank you, Viraj. Excellent lecture, really. I think you covered everything, and with your focus on mitochondrial myopathies, it was fabulous. Great. I urge all my faculty to, advise PGs as to how to prepare for these areas. Just a few last remarks. I used to find as a PG this area a bit more difficult than adult neurology, although and I used to have to mug up a lot of areas. So any special comments, Atampreet?
I think I'd like to just add a trick for the students who are going to give the exams. Never leave any question blank. If you look at any question, if you can divide it into basic headings, just exactly like we've done: introduction, a diagram, pathology, clinical features, investigations, and treatment. And I'm going to use the word TOCO. Just TOCO whatever you want under these broad headings. You have to have a basic idea of what that diseases, but you will be able to cover and get maybe half marks or passing marks for almost any disorder out there. You know, a lot of our neurological symptoms are the same. The treatment is always, as long as you put down physiotherapy and speech and occupational therapy, you're pretty much going to hit the nail somewhere. So don't leave any question blank, you know, and where possible, always draw a diagram. Diagrams get you always that extra mark or two that you need in the answer. So I think that's just a tip or a clue as to how to try and maximize the yield from questions, even if you find difficult.
Absolutely.
Yeah, I think
Harpreet, you
better
want
to
to
write in points. I think when you're writing a question answer, as you told, I think Dr. Viraj has already told, you better write in points. Etiology also you write 6 points. So I think instead of writing an essay like just write in point. I think that will give you more marks also because you can save some time also.
Absolutely, and comes to the attention of examiner easily.
Yeah, actually, yeah.
Absolutely. I think we've had a very nice session, very useful session today, and we're going to have one more on pediatric neurology. I thank all my faculty speakers for taking so much efforts to make these lectures really elaborative and useful for my PGs. Thank you very much.
Thanks a lot, sir. Thanks a lot.
Thanks.
Thank you.
Take care.
Thank
All the
you.
best to all of your
Good
students.
night.
Good night.
Best.
Take care.
Good night. Good night.